Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday edition. It's our great pleasure and privilege to have and host Dr. Mark Dunbar. Dr. Dunbar has been a member of the optometric staff at University of Miami's Bascom Palmer Eye Institute for over 30 years. He currently serves as Director of Optometric Services there. He's also co-chairman of the Conference Advisory Board for Vision Expo. Dr. Mark Dunbar is a fellow of the American Academy of Optometry. He is a founding member of both the Optometric Glaucoma Society and the Optometric Retinal Society. He also serves on the editorial boards for Review of Optometry, where he writes the monthly column Retina Quiz. Mark has been a tireless advocate and educator for optometry. He is a long-term colleague, mentor, and friend of ours. And it's really my great privilege and your great privilege to see and hear Dr. Mark Dunbar. So Mark, please take it away, as I'm sure everybody's giving you a virtual round of applause.
Well, thanks, Joe and Greg. Really appreciate being invited, and great to be able to spend some time on a Sunday night. This is really kind of a lecture that, if you will, is probably over 30 years in the making. It's really kind of an anthology. I spend time on some anterior segment stuff and posterior segment stuff, things that have really been an interest to me, things that interesting cases that I've kind of gone through over the years that I think are kind of fun to talk about, and hopefully you'll find interesting. Not too many zebras. It's really meant to be more clinically related, and really try to relate and identify with kind of the questions that we all have when we see an interesting patient who walks into our office, and there's obviously a question that needs to be answered. We try to figure things out. We have to make a decision. Do I treat it? Do I refer it? And so that's really kind of what the theme of this will be. Let me see if I can advance here. There we go. This is what the Bascom Palmer Eye Institute looks like. This was a hospital that was built in the mid-1970s, and it was built in an era when, if you were going to have cataract surgery, you were admitted for probably even up to several days, I would venture to guess, maybe longer. If you were having a retinal detachment surgery, you were certainly in the hospital for at least a week. And so at the time it was state of the art, but today it's a little bit of a dinosaur. So the 6th floor is all operating suites. The 5th floor is all in beds. And we do maintain a hospital accreditation. So it's not inexpensive to come to Bascom Palmer for your care. So not only when patients come are they charged their professional fee. So if they're coming to see Mark Dunbar, whatever, if we decide to use I codes or E&M codes when we're billing them, but they're also, patients get charged a facility fee because we're a hospital. So it makes it a little bit expensive. I thought what I would do is really kind of talk a little bit about, at least for the first few minutes, what is Bascom Palmer? I mean, it's a name that many people are familiar with, but really, who is or why was it called Bascom Palmer? And so the reality is that he was a physician who came to South Florida in around the 1920s. And he was a well-known, well-respected, very philanthropic ophthalmologist in the community. He was, as I said, well-liked, well-respected, and it was really his vision to start a medical school, the University of Miami Medical School, in 1946. And then, of course, he wanted to have a department of ophthalmology. Unfortunately, he passed away before the Eye Institute was opened, and it, I think, opened up in 1956 or 1958, but it was named after Bascom Palmer. Dr. Norton is really the one who, I think, really put Bascom Palmer on the map. He was the one that was recruited from Boston to start the ophthalmology program at the University of Miami. Dr. Norton was both trained in retina and he was trained in neuro-ophthalmology. And he really had a mentality that, he wanted his patients to have the very best. And he brought in really all-star faculty, people that would support the Institute, people that he thought were bright. And he just kind of turned the reins over to them. We'll talk a bit about that in just a few minutes, but this is the very first Bascom Palmer in 1962. They dedicated this 30,000 square foot building on the east side of the medical school campus. And so this was kind of where Bascom Palmer was housed for many years until 1976, when the building that you see here had opened up. But you look at some of the really iconic faculty. Don Gass came from Tennessee. He was from Vanderbilt is where he went to medical school and I think did his ophthalmology program. But, you know, he really pioneered the use of fluorescein angiography. He really had a passion for understanding retinal disease, and he was regarded as one of the top retinal specialists of the 20th century. Dr. Gass, I think he may have been a little bit deaf because he talked, you know, very loud with a Southern accent. And he was the kind of guy that he didn't care, you know, what your initials behind your name were, whether you were an OD, an MD, a DO, an RN. He really had the mentality, if you wanted to learn, there was always a place for you. And, you know, I remember, you know, many patients that he would look at, we would look through the teaching scope and, you know, he would kind of talk about and describe what he saw. For many, many years, he led the fluorescein angiography conference. And, you know, again, as ODs, MDs, residents, fellows, everybody was invited, and there was really never any issues with regards to that. You may not know, but the very first vitrectomy was performed at Bascom Palmer. Bob Mockenmer in 1970 really kind of conceived the idea of doing a pars plana vitrectomy. This was kind of a vision that he had in his garage. He kind of practiced on eggs, trying to figure out how to do that 3-port, 4-port vitrectomy, as opposed to the traditional open sky method, which was really kind of the way it was done at the time. But he was really the first one in 1970 to do a vitrectomy. Doug Anderson, who's really always been a friend to optometry, he was the one who really kind of discovered that elevated IOP impairs axonal transport in the optic nerve. He was really one of the kind of the kings of visual field. He wrote a world-renowned, world-famous visual field book. Of course, he was one of the authors in Clinical Decisions in Glaucoma with Hodap, Anderson, and Parrish. And of course, there's Dr. Parrish right there. And he was our chairman for many years. And again, both of them, I think, have always been, I think, great friends to optometry. They've lectured at national meetings. They've really loved to teach. But Parrish was credited for really the first one to use 5FU, 5-fluorouracil, and that was when he was doing his fellowship at Wills. Of course, Paul Palmberg coins the term target pressure, which is really kind of our kind of everyday vernacular when we're seeing patients with glaucoma, and he was also great to work with. Culbertson in 1993 identifies herpes virus as one of the causes of acute retinal necrosis. In 1998, he performed the first successful posterior lamellar endothelial transplant, and he still practices as well. Of course, our chairman is Eddie Alfonso, and he was really on the front lines of when we were kind of dealing with fungal infections from the renewed contact lens solution. He was, you know, kind of really the point person, I think, across the United States for that, if you will. And then Phil Rosenfeld, you know, interesting, you know, Phil is a well-known retina specialist, but he was the very first one to begin using Avastin, right? So remember when these clinical trials for Lucentis was going through, I mean, they knew this was going to be a big drug, right? Even though you're doing a clinical trial and you're kind of masked on, you know, which is the treatment drug and which is the, you know, the control drug, if you will. But I think they knew that Lucentis was so good early on that this was going to really be revolutionary in terms of really the first real successful treatment for macular degeneration. And so you can imagine having this drug that, you know, works, it's really going to change the game, and yet it's not FDA approved. And so he was one to recognize that we had Avastin, which was already FDA approved for treating metastatic colorectal cancer. And so he was the first one who said, listen, these are essentially the same drugs, very similar drugs. And he started using it, of course, in macular degeneration and diabetic retinopathy patients. And lo and behold, the $50 drug ended up being almost as good as the $2,000 Lucentis drug. And of course, you know, the rest is history now, as they say. We've got several satellites. We've got one, really a very large facility on the bottom right. This is in Palm Beach. We have one in Naples, west coast of Florida. We have one in Fort Lauderdale and Plantation, and then a newly built one, part of a hospital that the University of Miami built on the Coral Gables campus. And so, of course, we've got a great basic science. This is the Mcnight Vision Research Center, which is really a part of the Bascom Palmer Eye Institute. I think many of you, if you're as old as I am, and I just had a birthday, I won't tell you what it is, but it's up there, believe it or not. But growing up, probably many of us remember that good housekeeping seal of approval, right? That you wouldn't buy an appliance unless it had that good housekeeping seal of approval. And so around the mid-1990s, they began giving that good housekeeping seal of approval to hospitals and subspecialty services. And in 1994, Bascom Palmer Eye Institute was named the #1 eye hospital in the country by this Good Housekeeping magazine, which kind of finally gave way to U.S. News and World Report's best hospital edition. And so we've been named #1 eye hospital in the United States for 19 consecutive years, which is really an incredible accomplishment to really have. Let me tell you a little bit about optometry at Bascom Palmer. Our first optometrist was hired, Don Hoffer, in 1974, followed by Dr. Pappas, who was the one who hired me and was my boss for many years. And he really served as the director of optometry, went on to get his MBA, and essentially ran Bascom Palmer Eye Institute from a clinical side. He wasn't the medical director, but he was I think a chief operating officer, if you will. And again, it kind of goes back to Dr. Norton, who I kind of mentioned was really started Bascom Palmer. It was his kind of feeling that his patients really deserve the best, right? And he didn't really like working with technicians that much. And he thought really between optometry and ophthalmology, these two professions would complement themselves very well, and patients would, more importantly, be better served by having optometry and ophthalmology work close together. And so he brought in, again, Dr. Don Hoffer and Charles Pappas in 1974. And of course, the legacy was established. Interestingly, Dr. Norton had this idea of really establishing a college of optometry at Bascom Palmer Eye Institute. And the interesting thing was he had sold the idea to the Florida Society of Ophthalmology to start an optometry school at Bascom Palmer. Unfortunately, the Florida Board of Optometry wouldn't go for it. And so again, I think back, I'm sure his vision of optometry would have been very different, and who knows how far our profession would have gone under ophthalmology, but that was really the issue, right? As a profession, we couldn't be under optometry, but I think it just speaks to his vision of really both professions working together, really in the best interest of really serving our patients. And so we had a residency and externship program in the 1980s. It ended due to some of the political pressures. And so essentially what we did, we would hire new graduates from colleges of optometry. And that's really how I started in 1987. It was really kind of viewed as a pseudo residency. We got paid a little bit more money than traditional residencies did. And it wasn't a 1-year term. You could stay as long as you wanted. And so typically people would stay for 2 or 3 or 4 years, and then they would leave and typically often go into co-management centers. And in 1994, we were able to reestablish the residency and our studentship externship program. And you look at it since 1994, we've had really over 130 residents go through. We've had probably several hundred fourth-year externs go through as well. And it's been, I think, a great dynamic, at least personally for me, to be able to have worked with so many great students and residents over the years. And they've really, I think, contributed a lot to Bascom Palmer and certainly our profession. And so with that, let me kind of dig into some cases. First case is Chris. Chris is a 40-year-old white male who, by the way, happens to be an optometrist. And so Chris lives in Central Florida around Orlando. He was on an airboat going through some of the lakes and rivers in Central Florida when he felt something go into his eye. And of course, he's an optometrist, as I said, so he has access to antibiotic drops and steroids and so on. So he started using tobramycin in his eye, which he used for about 2 to 3 days. When it didn't really get any better, he switched to Predforte. And so he was using that every 2 to 3 hours. And this was a week before this picture was taken. Well, Chris and his wife had planned on coming to South Florida to get away. They were going to spend some time on South Beach and really have a little mini vacation. And so he called me up. I've never met Chris before, but he says, "Listen, Dr. Dunbar, I know you're a Bascom Palmer. This is my story. My eye's been irritated for the last week. Can you see me?" And of course, I was going to be happy to. And if I couldn't figure it out, we would kind of triage him to one of our cornea specialists. And so this is what his cornea looked like. And I'll kind of give you a kind of a bigger picture, right? So essentially what you're seeing are these subepithelial, very focal, kind of gray putty-like spots really scattered throughout his cornea. And the question I'm going to ask you in a little while is, what do you think this represents? And I'll tell you, I didn't really know at all. So needless to say, I did walk him up to our cornea department, had one of the cornea specialists take a look, and we ended up culturing him. You know, kind of one of the themes that we're going to talk about here over the next few minutes is you know, this non-specific red eye that comes in, that's sitting in your chair. They've got a problem. You're looking, and again, some things are very typical, right? And we'll look at a few typical things in a second that you look, you automatically know what it is, you know how to treat it, you initiate therapy, but a lot of times you don't. And so, you know, what do you do in that scenario where clearly there's pathology, clearly there's a problem, but yet you don't know what it is that's causing the problem? And then with that said, how do you treat it when you don't know what it is that you're trying to treat? And so the question is, what's going on? Well, let me show you another one, because this is a patient who I thought looked very similar. So fast forward probably another, that was 2013. So maybe 5 or 6 or 7 years later, right? This is a 23-year-old rookie pro football player. He had graduated from the University of Miami, gets drafted by the Dallas Cowboys, and he's in training camp where he starts to notice pain and irritation and photophobia in his left eye that he really had for the last week. So he is a contact lens wearer. And before training camp had started, he says that they had spent several days in the Bahamas, as he described it, living this kind of bohemian lifestyle, right? They were on a boat, they were doing a lot of scuba diving and fishing and snorkeling. And, you know, yes, he's wearing contact lenses. They get out of the salt water. He kind of rinse himself off with the, with the shower that's on the boat. And so now he's in Dallas, and it's the first week of training camp, and he's got some pain and irritation in his left eye for the last week, and it really bothers him. And so here's what his cornea looks like. So I guess it's a 2-year difference. That first case was 2013. This is 2015. I thought they were a little further apart, but really almost a similar appearance, right? These kind of focal, subepithelial, discrete, lesions. And so, same question, right? He's got this non-specific red eye. He's got a keratitis. Would you treat him? What would you treat him with is really the question. And so you look at really both of these patients who, I think they look like they have strikingly similar corneal pathology. And so, what's going on with this patient? And I think, Greg, we're going to really open this up as a poll question. What do you think they have? No clue. I have no idea. That's why I'm here. Could this be something weird and unusual like microsporidia? Could it be acanthamoeba? Could it be Tygasons, or could it perhaps be herpetic? So what do you think is going on with both of these patients? These are the tough ones, right? As I said, where you're, looking at corneal pathology and you're not really sure what it is. And again, that question doesn't look like anything that you're real familiar with. And you know what we talk to our students and residents about, right? Anytime a patient comes in with a red eye, obviously it starts with a good history, what incited it, but also paying attention, I think, to the fundamentals. Do they have a preauricular node? Do you see follicles? You kind of go through that scenario as you work through. If they've got follicles and if they've got a node, it typically points you to viral. And of course, we're very familiar with some of the more common viral etiologies like, EKC or herpetic eye disease. If they don't have follicles and don't have a node, you can kind of cross, viral off the list. And then you kind of move on down the line of what you think it is, again, based on, is there a contact lens history? Do you see corneal epithelial defect? Is there papillae? And so
Mark, you can take a breather there for a second, and
okay.
The poll is launched. I'm sharing the results. What I want everyone to know is I just put your hand out into the chat box, even though it's shared via the email 645 and further ones. But if you want to download it now, it's in the chat to be downloaded. And I just need a few more people to respond. We got to about 72%. This needs to be live and interactive out there to meet with all the compliance. So thanks, everyone. Okay, Mark, go ahead.
Thanks, Greg. Should I give him a few more minutes? So about 30% of you said microsporidia. About 16% said acanthamoeba. 35%, a third of you said Tygasons. Well, it's not really a trick question. because, well, let me kind of go forward here. I'll tell you, Chris, the optometrist, what his cultures ended up growing out was microsporidia. So this is an intracellular protozoa, and patients present with this coarse epithelial keratitis, typically, some redness. And by the way, I've seen microsporidia. I've had several cases of microsporidia, and when I had seen it, this was in the height of the AIDS epidemic in the late 1980s. So these patients would come in with this really coarse, what looked like just typical dry eye, right? We know what SPK or PEE is, right? And this is what it looked like when we would see the AIDS patients. And these were, of course, people who had CD4s of 0s, 1s, 2s. I mean, they were severely immunocompromised, and so obviously at risk of developing a number of infections. And so, back then we would see, of course, CMV, we'd see a lot of toxo, we would see a lot of kind of weird and unusual things. But I remember a couple patients that I would see in our primary care clinics had this very typical presentation of microsporidia. And again, these were patients who were very immunocompromised, as I said. Interestingly, we would treat them with fumagellin. And so Chris grows out microsporidia, and we actually ended up treating him with natamycin, and very quickly he ends up getting better. This is one of the AIDS patients that I saw. And again, if you look at it, I don't know how, I probably should do a side-by-side between this patient and what Chris had and really kind of compare the difference. These patients had much more diffuse disease. Now, this isn't what our football player had. So he actually came in with a tentative diagnosis of acanthamoeba. And that's why they put him on a plane, send him to Bascom Palmer. I was the one who triaged him and ended up having him see one of our cornea folks, Eddie Alfonso, and they did confocal microscopy and agreed that this was most likely acanthamoeba. And they put him on the typical acanthamoeba regimen of Bacquicil, chlorhexidine, and Vigamox. Bacquicil, I think, is a pool cleaner, so it's not easy to get, and I don't think chlorhexidine is either. But as I said, I mean, when I looked at him, I thought that, they looked very, very similar. And so when I saw him, I go, I'll bet this is microsporidia. And of course, they decided to treat him with acanthamoeba. And really, I think we caught it early. This is him 2 days later, and he's already starting to feel much better. Unfortunately, he ended up having to go back to Dallas, back to training camp. And the sad story is that he ended up being cut on the last day of training camp. And I think he was picked up by another team, and I think he's still playing in the NFL someplace, but I thought he was very interesting. And so, yeah, kind of the scenario that we talked about. What do you do, right? That unilateral red eye, pain and photophobia, it looks like a dendrite. Here's a patient who actually ends up another case of acanthamoeba, but in the number one misdiagnosis of acanthamoeba typically is HSV. And you can see they get this perineuronal neuritis, and you can kind of look at that and see how you could think that this could be herpes simplex. And so that's the question, right? Do you treat it as HSV, or, some of these conditions are so rare that they're not even on your radar, like microsporidia or acanthamoeba. And I think we certainly understand that depending on what the inciting event is, whether it's a bacteria, fungus, virus, many presentations, it's based on the inciting event and then your body's immune response to that event. And very typically, you look on the bottom left, right? Everybody on this kind of lecture here, this walks in the door, we know it's herpes simplex. This is a contact lens where they've got an infiltrate, they've got a hypopyon. This ends up being a very typical case of Pseudomonas aeruginosa. And then this one kind of feathery, ends up being fungal, right? So, but that's not always the case where they come in and they have a very typical response. Again, this is a patient where you kind of go back to the fundamentals, and there's some things here on the slide that you may not maybe recognize immediately, but you can see that there's some follicles present, right? And he does stain with Rhodes de Mengele. This is a construction worker who happens to be a Friday. It's, late in the day, and he's not getting any better. So he finds his way to Bascom Palmer, and you see this large geographic ulcer with follicles in the presence of a preauricular node. I think you can kind of see this, this what was probably started as a dendrite. And so this is maybe a more atypical presentation of a herpes simplex epithelial keratitis, but in this case, it's a geographic ulcer. And so, yeah, this was kind of some of the things we already talked about, right? Is there a node present? Do corneal sensitivity if you're concerned or thinking about HSV. Use your vital dyes like rose bengal, like fluorescein. Do they stain? What is the character of that staining? And that sometimes help you. But yeah, this is the question, right? You're looking at it and you're like, do I treat it? Do I not? Do you wait a day? And have them come back the next day? Because as we know, depending on when this started, it may not kind of manifest itself in a very typical way, at least at the time you're seeing it. And so, certainly it's an appropriate option to wait a day, but here's the psychology, right? Here's a patient who clearly has a problem. They've taken time off of work. They're sitting in your chair and you're like, let's just, wait a day and we'll see you back. Right. And sometimes that's what you have to do, but they want an answer and you feel an obligation to come up with an answer, to give them what the right answer is and what an appropriate treatment would be. But as I said, that's not always easy and maybe even reasonable and realistic in certain circumstances, especially like the two cases that I just showed you.
Hey, Mark, before you go too deep here,
Yep.
We had one of the docs put interesting. I think I wanted to say responded. Interesting, he responded to natamycin. I believe that microsporidia is classified as a fungal. And I think I think you kind of mentioned it and maybe you did use an antifungal, but maybe the natamycin in a sense supported and the body maybe eradicated it itself. But
yeah, well, I think natamycin is an antifungal, right?
I'm sorry?
Natamycin is an antifungal.
Oh, yes.
So I think that's why I think when you read the literature, as I said, it says it's an amoeba, but it has, I think, some characteristics of being a fungus. I don't know what fumagellin is. And again, back in the day, we would compound fumagellin and that was kind of how we treated it. Certainly I didn't, but we would kind of send it to cornea and that's what they did. So, but I think it has characteristics of a fungal to your point. And I think that's why we finally got the right drug and he ended up doing really pretty well.
Perfect.
So this is kind of along the same line, right? This is a nurse who happens to be a good friend of one of our former optometry residents who they traveling companions. And so she says, boy, I've had for the last 2 weeks, especially when I wear my contact lenses, I get really blurry vision. And you look at her acuity, she's 20/80. Now, she also gives us history, which I'm not too sure how relevant it is, but she says 2 days ago, she had an episode of distorted vision in the left eye that lasted for 30 minutes and it goes away. It wasn't accompanied by any pain or discomfort. But again, this blurred vision, 2 weeks associated with contact lens wear. And what we're going to see is, guess what? Here's her cornea. And, what I'm thinking when I'm looking at this cornea that I think, and it's really only one eye. It's the left eye. It's not the right eye. The right eye is clear, but I'm looking at this and I'm remembering the other two cases. I'm thinking, wait a minute, this looks like microsporidia. And again, they kind of they're translucent, coarse. How do you manage it? Same type of thing, SPK. And again, we kind of concluded that perhaps this really fits more of a Tygeson's presentation. But as I said, microsporidia was kind of along the list. Now, as I said, she's a nurse, works in a hospital. And so we wondered if there was anything that maybe that she interacted with being in a hospital. She works at Jackson Memorial Hospital. And so so the same thing, right? So is it Tygeson's, but it's a little atypical. How do you treat it when you don't know what you're treating it with? And so we ended up just putting her on artificial tears. She wasn't that uncomfortable. She really wasn't that red and that uncomfortable anymore. It was really just the blurry vision. So we ended up essentially just putting her on artificial tears. She was fine with that, kept her out of her contact lenses, a lot of artificial tears 4 to 6 times a day. But again, I kind of go back and I'm remembering, the other two people I just showed you. I'm thinking, boy, she looks really very similar to the others, and maybe not when you look side by side. And she continued to get better in it, but it took a while. The question, this clarity of retrospect, right? If you think it's Tygeson's, why wouldn't you treat it with a steroid? And I wanted to treat it with a steroid. Our Eddie Alfonso, who's again, probably I think one of the greatest cornea specialists there is. He's a little more conservative, and he said, you know what? Let's just she's doing fine with artificial tears. She's, wasn't too anxious really at this point. And it ends up, I saw her over a couple of weeks and she ended up, essentially resolving completely on her own. And ended up kind of, that was the last time I saw her. But, Tyguson's SPK, numerous round or stellate areas, of course, gray, slightly elevated intraepithelial lesions, mild to moderate foreign body sensations. Anytime you have corneal pathology, I think you recognize you're going to get some tearing, photophobia, foreign body sensation, et cetera. And again, I think what's interesting is we still don't know what is the exact inciting event or etiology of Tyguson's. It's thought it's subclinical viral infection, but really when they've done cultures and really have tried to investigate, they've really not been able to figure anything out. So as you said, some people have thought it was varicella, possibly herpes, possibly Epstein-Barr, as even chlamydia has been thrown out there, but nothing really has kind of fit that. This term SPK is interesting, right? We just had our new batch of residents started on July 1st, and I've been working with them the last few days, and we do these same day post-ops, cataract post-ops. So they have cataract surgery in the morning, and then later in the afternoon, we call them post-op day 0. So we're looking at these post-ops, and that way, because it's a Friday and they don't have to come in on Saturday, and we're kind of dotting the I's and crossing the T's. But there's one of my residents who's from Pacific and the other one is from UAB. And it was interesting because the one would call it, because they have a lot of exposure, right? And so a lot of, keratitis. And so one was calling it PEE, punctate epithelial erosions, and the other was calling it SPK. And so I asked the question, I go, well, what's the difference? Why are you calling it SPK? And why are you calling it punctate epithelial erosions? And the answer is, if you want to be kind of the purist, really SPK should be reserved only for patients who you suspect as having Tyguson's. And so I know many people use it interchangeably. We know what SPK is, and at least when we're looking at the slit lamp, and same with PEE, punctate epithelial erosions. But the point is that really you should only use SPK if you think that this is a Tyguson's. Otherwise, you should use PEE, punctate epithelial erosions, to describe these kind of dry eyes that have, PEE. So anyhow, just kind of a tidbit. I don't think it really matters for the purists out there. The last one, let me burrow through Caitlin. I think we have other things to talk about. She ends up having Tyguson's as well. She's a contact lens, I think Tyguson's. It took us a while to figure it out, but again, these kind of same course punctate epithelial erosion, pseudodendrite, that we didn't know if it was related to really her contact lens polymer. I think she was wearing silicone hydrogel lenses, and she would do fine except when she put the lenses in, and she would wear them a couple of days, and then she'd go through these episodes where blurry vision, uncomfortable, pain, photophobia, and again, it kind of took us a while to figure it out because we went down the path. Is this really from her contact lenses, or is this Tyguson's? And I think ultimately this ended up being, we put her on a steroid and it ends up being Tyguson's. Let's kind of move on to something else, right? So again, kind of still focusing on anterior segment disease. And again, the idea of a patient who comes in with non-specific, maybe dry eye, right? So they're got foreign body sensation. They describe dryness, irritation. And again, we see dry eye patients every day in our practice. We see blepharitis patients. We see patients who have allergy. And we've all heard the lectures, and of course we can identify it. We know how to treat it. But I think probably one of the most difficult things that we do as clinicians is trying to decide, really what is the ultimate etiology of this patient who is experiencing dryness and irritation and foreign body sensation. And again, the idea that when you listen to the lectures, that none of these diseases exist in a vacuum, right? And so often there is overlap. Allergy patients, we know the hallmark is itching, but guess what? Dryness, patients can have itching as well. And so I think, especially as a young clinician, when you've just graduated, you're seeing these patients and you've learned all this stuff, but yet you don't always recognize it. There is overlap. And I think it's very difficult to kind of distinguish and differentiate. there's no question, patient who has dry eye, but, they've got symptoms of allergy, they're itching, I'll put them on Pataday, right? And yes, I'll put them on an artificial tear, but, my kind of mantra is let's treat why they're here. If this is a patient who's got bad itching, yes, we can, of course, make our diagnosis of dry eye or recognize that they've got meibomian gland disease or collarettes and whatnot. And we try to identify and treat, do targeted therapy. But, I think the point is it's not really very easy to do. And so this is a case. I'm going to highlight this point. This is a 23-year-old Hispanic male. He's got some, itching and discharge. He doesn't use any drop, but again, itching is really one of the hallmarks of his symptoms. And again, he almost has discharge. And so, as I said, when somebody has itching, I typically think allergy. But yet he's also got this kind of mucus discharge is what he ends up having. And so kind of listen to my case history with him, and then we'll try to figure out what he has. That's going to be the next poll question after this. Describe exactly how you. Wait, I'm going to try to.
When I did them, and I just rub it off.
And how many times a day do you do that?
Like 10 times.
Yeah. For how long has that been going on?
For like a year.
A year. All right. But you also have some itching, is that correct?
Correct.
Okay.
So I'm sure everybody knows what this is, but we're going to do the polling question anyway. What does this patient have? Is it chlamydia? Does he have seasonal allergic conjunctivitis? Does he have blepharitis? Does he have dry eye? Could this be mucus fishing syndrome? Or you're not sure, and that's why I'm here. What do you think this patient has? We're going to look at a couple more examples of this, but and I'm going to venture to guess most people are going to figure this out. But it's a very typical kind of scenario. Asking, all right, you get itching, you get discharge. How often do you get the discharge? Show me exactly how you remove the discharge. And I have patients, exactly what you just saw. Show me. Let me see you do it. And I think we're kind of figure out what he has here, right?
There you go, Mark. There are your results.
Wow. I would have expected you probably didn't get mucus fishing syndrome because maybe you haven't heard of it. But if you've heard of it, this is a very typical kind of scenario. Now, looking at him, he could have chlamydia too, but that's not what I think is going on with him. Listen to this. I got two more histories. So let's listen to this one.
Exactly how you remove it.
Like that, and then it's a loss. I go like that,
Show me.
and then I gotta wash my hands.
But show me exactly. I mean, it's
Like,
like you can't see, so do it again. Just like that. Huh?
like that.
But how many times a day do you do that?
A lot.
Like 10, 20? Lots.
Yeah.
Okay.
I have to be washing my hands constantly.
Okay.
And so it's that mechanical, trauma of on the conjunctiva that ends up this kind of cyclic cascading event of producing more and more mucus in response to them pulling it out and causing damage and, to the conjunctiva. This is my favorite one. That you'll like this one.
Show me exactly how. Exactly.
Yeah, there you go.
And you get some mucus out of there?
Well, not right now. It's not.
There you go.
Sometimes I have to go like this
Mhm.
and get out.
So how often do you do that?
Very 10 times, 5 times, sometimes a day.
A lot.
Or get it something clean and
Same
put that
thing.
thing in the corner. Yeah,
Yeah.
to get out.
So, so again, almost all three cases really, really very similar, right? Here's the kind of the original description by James McCulley out of Dallas, who was the first one to describe mucus fishing syndrome in 1985. And again, this is kind of the typical how they do it, right? They pull it down, they try to, they feel the mucus in their eyes, and when they feel it, they feel like they got to remove it. And by trying to remove it with that, aggressive damaging the tissue, more mucus gets produced from the goblet cells, and it becomes kind of a vicious circle. And again, you can kind of see the little bit of mucus that's sitting there. And there hasn't been a lot written, right? So this was McCulley's original paper in 85. There's a married couple that work at a VA in, I think, Virginia or West Virginia, the Schlegels. They kind of reported a case that they thought was related to allergy. So there's no doubt there's an inciting event. And in this case, they thought the patient, had started with seasonal allergic conjunctivitis. And then that really kind of started the cascade where, it wasn't until they treated the underlying problem, in this case, the allergy, that they were able to kind of stop it. And so again, maybe they had previous viral conjunctivitis or allergy, or maybe they are going through a period of episodic dry eye. And that really kind of starts the cascade, if you will. So, part of it is identifying, recognizing that that's going on. And again, it's in the scheme of a busy day. We good?
Got it.
In the scheme of a busy day where we routinely see dry eye, blepharitis, seasonal allergic conjunctivitis, we're good at kind of deciphering these histories and kind of coming up or picking out what we think is the right cause. And you can see that there's overlap. Some of these symptoms are very similar. And so it's easy to say, all right, let's just do an artificial tear, or let's, give you a mast cell stabilizer, or, do an OcuSoft with, hot compresses and lid scrubs. But if you listen more carefully, this is a very typical scenario of how these patients kind of present. Trying to go. There we go. So yes, treatment includes eliminating the initiating event. And so again, once patients are aware that they're kind of part of the problem, I think they're pretty good about breaking the cycle. Again, just using an artificial tear, a soft cloth. I've never used a mucolytic agent. I've certainly have done artificial tears and a mast cell stabilizer, but and it works. And this is, of course, Paula Jamian has a column in Review of Optometry. He's done that for many years. And this was kind of an example of that, right? And you can see this is a patient stained with Rosenfeld, and that's because of the mechanical trauma from trying to constantly extract the mucus out of the lower fornice. Here's another blog, pretty sure I have mucus fishing syndrome caused by my allergies. And so she goes on to really kind of describe the scenario, almost exactly what we talked about, this having mucus fishing syndrome, and she's tried everything. She ends up kind of being able to kind of self-identify, there we go. Stop the fishing, reduce inflammation, break up mucus, treat the underlying etiology. All right, so this is Isaiah, and there's really no mystery to what Isaiah has. You're going to see it in a few seconds. I think the question really becomes, how do we treat him? And he is kind of in my top 10 of interesting cases that I've seen over the years. So he comes in, this is over 10 years ago, right? Isaiah's 9. He's got itching, irritation, left worse than the right, tends to be seasonal, worse in the last month. Here's kind of an external shot. And again, that doesn't help you, but when you get him at the slit lamp, right, clearly you see he's got a lot going on. And he has, probably the worst case of limbal vernal, keratoconjunctivitis, blepharoconjunctivitis that I've seen. You see those Trantis dots that really go around the limbus, very characteristic of vernal. Here's the left eye. You flip his lid, and he had some pretty large papillae. You see one in the left eye, very large one right here. And so, as I said, I think that, the diagnosis really wasn't a difficult one, right? Severe limbal vernal keratoconjunctivitis. The question is, how do you treat them? And so I think we'd probably all recognize, because it's vernal and falls into that kind of IgG mediated, cascaded, you'd probably certainly treat it with a dual acting mast cell stabilizer. But the question is, do you put them on a steroid? And I would assume that we probably all would, right? So not only do we put him on a dual acting mast cell stabilizer, but let's treat him with a steroid, because he does have a lot of inflammation. And so the question is, our next poll question, which steroid would you use? Would you keep it as simple as an FML? Would you do a Predforte? Would you do kind of a Lotomax, Lotoprednol? Would you go for a big gun Durezol? Or, despite everything I've said, would you say, you know what, I don't feel comfortable using a steroid on him? What would you do? FML, Pred, Lotomax, Durezol, or you wouldn't use a steroid? What are your thoughts on this?
And Mark, while this poll's going off, I'll just let everyone know I'm going to put the handout in there one more time.
Thanks, Greg.
Yep.
You can always interject as well if you'd like, Greg.
Yeah, perfect. Yeah.
Yeah, I don't mind.
Nothing yet at this point.
Yeah, all right.
Doing a good job.
Thank you.
Nothing in the questions, just the one question so far. Everything's good.
All right. So what steroid do you use?
Here we go. I'm going to let you know what the audience feels.
All right.
Share the results.
All right. So everybody would use a steroid. The question is which one? And I went with the majority. 63% of you said you would have used Lotamax. About 23% said you'd use Pred Forte, and about 10 or 11% said FML. Well, I thought FML was probably not quite big enough. And so to me, it came down to either Pred Forte or Lotamax. We know that Pred is probably a little more potent than a Lotamax, but I thought Lotamax was probably going to be potent enough. And what really I like the safety profile. You know, one of the things that I find with some of the allergy kids, and I've got several of them, they really do respond to steroids pretty well, but sometimes it's tough to get them off the steroid. And so I ended up using Lotamax. I debated, should I do Pred Forte? Again, I like the safety profile of Lotamax, and that was kind of the reason I did it. The question is, was that the right decision? Was that the right decision? So here's what I did. Lotamax, Pataday. He comes in 2 weeks later feeling much better. You can see in the right eye, you know, all those limbal kind of vernal changes completely have melted away. And now you're looking in the left eye. And again, he's got a few, but he's really looking much, much better. Mom's happy. He's smiling. He's happy. And so I say, let's just kind of stay the course. Here's the right eye. You can kind of see that blown up a little bit. Here's the left eye looking much, much better. So doing much better. Let's continue the Pataday. Let's kind of start decreasing the Lotamax from 4 times a day down to 3 times a day. And we'll have him back in a couple weeks. And guess what happened? Boom. He comes in. Yeah, he's doing better in the right eye. But take a look at that left eye. What the heck does this represent? And so that's going to be another question. Does this represent a shield ulcer? Is it a bacterial corneal ulcer? Is it geographic herpes simplex ulcer, or just a corneal epithelial defect non-specific? And I'll let you look at it again. What does this represent? Shield ulcer, bacterial corneal ulcer, geographic HSV, or corneal epithelial defect non-specific? What do you think this is? And of course, the question is, how do you treat it? And I didn't answer that. That's not a question that we're going to ask, but that was one of the, like, gosh, how do we take care of this? And so, yeah, I'm feeling pretty cocky, feeling like I've, done a great job. And all of a sudden you get thrown a curveball, and I remember, because here's the question, right? Is this have to do with the steroid? Should we have not used a steroid? Did we use the right steroid? Did that have any influence on what was going on? And I remember, after I saw this patient, again, great pictures, right? And I ended up kind of, as I'm walking out, one of the cornea specialists is coming out as well. And I show him the case and he goes, "Oh, that's great. How'd you treat it?" And I kind of walked through the course with him. I use Lotamax, I use Pataday. Oh, that's all right, pretty cool, right? And so then he comes back, and the fact is, well, I'll show you in a second.
And Mark, one of the comments from another Mark,
yep,
was, I agree, but often difficult to get insurances to cover.
Correct.
And I agree. And but I do lecture with a pharmacist, and in 2019, I think it was Acorn, take that with a grain of salt, does have a generic suspension of this, not the gel form. So the current Lotamax is gel. Obviously, you don't have to shake it, but suspension you do. Yep. So the original 0.5% is in generic that's out there.
So at the time, this was 2010, so we didn't have the generic, but in South Florida, surprisingly, Lotamax, they had Medicaid, and they had really great coverage. Medicaid did back then. So it was a little bit easier to get
Yeah, Mark, when you were talking about this, I checked GoodRx in the Sarasota area. Cost price of generic Lodoprednol, and we know that there are numerous formulations and configurations of Lodoprednol, but the basic generic is about $63, whereas Pred Forte is about $25.
Yeah.
And that isn't a huge difference for most people.
Well, you know what, today I probably would do, Lodopred is not inexpensive. And so I probably, if I were doing this today, I probably would have done Pred Forte. Just because of, I know it's easily available, and it's on, many of the formularies, and it's cheap, but again, my point is still a concerning one. It's tough to get them off the drop. Now, let me show you as we kind of go through here, right? So if you were a keen observer, you would have seen that this was actually present, on the initial visit. And I did record it in my chart. And you can see that second visit 2 weeks later, you can see that it is a little bit bigger. And again, I didn't, I noted it, saw it was there. I didn't know what to make of it. I think I, again, thought about it, but didn't give it much thought until obviously he comes in the third time and you see this large shield ulcer. And so the question I always ask myself, again, had I done Pred Forte and not Lodomax, again, a little more of a potent steroid, could I have really prevented that shield ulcer from happening, and would it have kind of gotten better? So again, I ended up kind of walking him to one of our corneal specialists, and we kind of same thing. Dick Forster was the one who saw it. He's been around forever. He's now retired, and he's one of those guys. He's seen everything there is, right? And so we walked through the case, and it's great to have these guys that have had a lot of experience, and what I would have liked to have learned from him is, well, why'd you choose Lodomax? We did, I would like to have heard him say, well, I would have used this, or I would have done it this way. And he didn't do that. He just said, okay, all right, that makes sense. Well, let's go back to 4 times a day. We'll add, an artificial tear and just kind of keep it well lubricated. So we added Cystine free 4 to 5 times a day, and had him come back a week later, which he did. He was doing better. And then a week after that, you can see he's really completely reepithelialized. It's a little bit thinning, but he's completely reepithelialized and was doing fine. And this ends up kind of being the last time that I had seen him. So, yeah, I thought that was pretty interesting. This is just one of those kind of interesting show and tell cases. This was the last kind of anterior segment. We'll kind of move on to some retina stuff. This is a patient.
Hey, Mark, before you move on, there is a question that says, please describe a shield ulcer.
Great question. So we don't know why they develop shield ulcers. It's thought to be kind of an immune-mediated breakdown of the epithelium. And so, again, remember that large papillae that was underneath the upper lid. We'll go back here so you can look at it here.
Yeah.
So,
way back in the time, Mark, they thought it was like eosinophils building up. So kind of
right.
that going down that pathway of that inflammatory debris kind of building up, right?
Yep, that's exactly right. So all those have been kind of postulated as being a cause. It's not infected. You see that kind of gray base. That doesn't represent an infiltrate, a traditional infiltrate, like, in a bacterial corneal ulcer type sense. This is sterile. And again, it's just a breakdown of the tissue as a result of these immune complexes. And again, whether it's eosinophils or whatnot. And we didn't, there's probably, you could use a bandage contact lens, right? So that would have been a potential way to kind of treat this as well, in addition to the steroids. And again, some people would have been maybe uncomfortable with the steroid because of the fact that you got a large epithelial defect. And does that perhaps put the patient at risk of developing a bacterial ulcer or something along those lines? But
the way I kind of think of it, Mark, would be, we can probably learn from what we learned from COVID, right? We have patients that get COVID, they lose their taste and smell and nothing happens. And then you have friends and family that are dying from it, or it's they're having this cytokine storm. So what we've learned is not everyone has the same type of an immune system. And to steal what Dr. Offerdahl, the pharmacist that I lecture with, Shelley, says that immune system doesn't like to be tinkered with, right? Doesn't like to be messed with. And, this is probably just one of those, someone just has this is maybe cytokine building ups, something that it's out there and someone just having an abnormal immune response.
And that's really exactly what it is. They have their immune system overreacts to whatever it is. And interestingly, when you look at vernal versus even atopic, both of them are IgE mediated. In one instance, it's in vernal, it's a response to something in the environment. Attacking or reacting to whatever it is that is kind of causing it. So, but yeah, so it was, as I said, I look back and is this, could we have maybe avoided it had we used a different steroid? And again, of course, you never know because we can't go back in time. But great question. A patient, an 18-year-old who comes in, it's December 29th. So again, just kind of set the stage. Think about what's happening in your offices or where you work during that week between Christmas and New Year's, right? Things are fairly quiet, fairly, not a whole lot of action going on. Certainly not at our hospital. Many of the surgeons are taking time off. They're, spending the week with families, et cetera. So this is a kid, 18-year-old, who gets screened by one of our nurses who work in the emergency room and then kind of passes the patient on to optometry because they think, oh, this is not a big deal. Let's just, have optometry see him. And so he's got a very interesting history. He was in a motorcycle accident in that kind of June, July time. So in the summertime, really serious life-threatening injuries, multiple internal organ injuries, long bone fractures. I mean, the guy lucky to be alive, right? And so interesting, he kind of comments when he was kind of in the trauma center, he had this non-specific eye pain in his left eye. And apparently it was looked at, but, probably not with a slit lamp. And obviously he's got other things going on with internal organ injuries, bone fractures, et cetera. So he recovers, fast forward to December 29th, with this irritation, this pain in his left eye. And so he's 20/20, and this is kind of a step back version looking at him. And we're going to kind of slowly get a little bit closer. And I'm going to draw your attention. There's something right here, right there, as we kind of move in a little bit more. And there you go. He's got a shroud of glass that went through his cornea, probably like a cataract, surgery, right? It kind of beveled incision, self-sealed, but now he's got this piece of glass that's sitting really on his iris that's coming forward and actually touching his cornea. So you can imagine sleeping, rubbing your eye. He's got that constant kind of irritation of this, piece of glass that's sitting in his anterior chamber. And it's a beautiful image there, right? And so kind of the caveat to all this was that, he's under his parents' insurance and he's going to get off it in 2 days. And so he wants something done on December 29th or 30th. And because otherwise it ain't going to get paid for by mom and dad's insurance. And so I'm not sure what happened to him, but it was kind of one of those interesting ones that, again, like all of us, you never know what's going to walk in your door and what's going to be sitting in your chair. And sometimes they can be routine, but other times you get these kind of weird, unusual things that I think make what we do fun, interesting, and again, I think provides a great service to our patients. So let's switch gears. This is an interesting one, and I've titled this "A Closed Mouth Gathers No Feet," and you'll kind of understand here in a little bit. And kind of the question is, this is maybe a little bit of a sensitive topic, and hopefully I won't offend anybody as we go along here. If I will apologize in advance, but this is a 20-year-old college student who wakes up with blurred vision in his left eye. Really can't see much of anything. He sees red, of course. And you know, I see him on Monday and he's about 2,200 eccentrically viewing. And so the question is, you know, what's going on with this kid? Here's an OCT. And I think I asked a question here. I'll let you look at it, spend a little time, right? You see this area of hemorrhage in his macula, involving his macula, maybe a little bit layered. And the question is, what's causing it? What happened to this kid to kind of get this? And so does this represent a choroidal neovascular membrane? Does he have a retinal arterial macroaneurysm? Does he have maybe Valsalva retinopathy? Or does this represent a branch retinal vein occlusion that bled underneath a subhyaloid? What's going on with our 20-year-old college student waking up with blurry vision and he can't see out of his left eye? The imaging is nice, right? I mean, that's that's kind of nice to be able to have the tools at your disposal to be able to kind of look with an OCT. I also have OCT angiography that we done. I think this is a 8x8 or a 6x6 scan. You can see the kind of the layered blood, hypofluorescence here on the fundus autofluorescence from the blood. You can see that it's very superficial. So what do you think is going on with our boy here? Valsalva. Very, very good. That's exactly, this is, the nice thing about ODs on Facebook is, right, people, I love it when they post cases. I love looking at the tales from the trenches that get sent in by people. And you'll see, these kind of pop up every now and then. And so, yeah, it's just very characteristic of a Valsalva retinopathy. So we did that. So Valsalva occurs when a person tries to exhale air forcibly through a closed glottis or windpipe so that no air goes out through the mouth or the nose. And so what happens is that sudden increase in intrathoracic or intra-abdominal pressure occurs as a result of this forced exhale that you try to make. And so as we know, this happens really throughout almost all of our days, whether it's, working out, exercising, lifting weights, coughing, sneezing, vomiting, straining, going to the bathroom, blowing on musical instruments. The list kind of goes on. And so I asked him, told him what it was. And him being a college guy, I go, listen, well, were you at a party? Did you throw up? Were you kind of drinking too much? And, any type of Valsalva maneuver. And he says, no, none of those things. And so I happen to have a retinal specialist. This is in one of our satellite clinics down at Lamellar. And I showed him the images, and the patient was dilating when I said, I go, Jay, take a look, man. This is kind of an interesting case. And of course, we knew exactly what it was, Valsalva. We talked about the history. And so he goes, well, did you ask him about any vigorous sex? I go, well, no, I didn't. And I asked him everything else, but I didn't go down that path. Why? And he talked about when he was a resident, one of his co-residents had collected a number of cases of patients who had this Valsalva retinopathy that, as it turns out, during strenuous or vigorous sex, at the moment of orgasm, they can get this Valsalva type retinopathy. And I'm like, oh, great. So do I got to ask him these questions? And so here's where it gets a little sensitive, right? So, and so by the way, here's, you read the literature, precoital visual loss due to Valsalva retinopathy. And so they kind of describe it very well, that it's, and again, something you need to dive into when you suspect this and maybe trying to understand maybe why they have it. And so I'm going to paint a picture for you here, because here's where things kind of go south for me. So this is a 20-year-old, good looking, handsome, first, second year college student. You can tell he probably does okay. And he's with this beautiful, beautiful girl. I mean, she could be a model, blonde hair, just gorgeous, blue eyes. And so, he's out dilating. I'm kind of putting two and two together. And I'm like, oh man, I think I got it. I know why. And so as he comes in the room and he's dilating, I go, you know what? I go, we talked about, this Valsalva, but there is another reason why you could have gotten it. And I tell him that during vigorous sex, this is something that has been reported and described. And so as I'm looking at him and then looking in the back of the room with the patient, the girl that he's with is in the chair, and I'm kind of looking at him, looking at her, looking at him, looking at her, thinking, you can say it, right? And he looks and he goes, "Oh, that's my sister." And I'm like, "Oh, okay." So closed mouth gathers no feet, right? So, but anyhow, he denied anything like that could contribute to him having his Valsalva. So yes, learning. What's that?
Mark, it's sometimes challenging to broach that subject. I remember several years ago, I had a patient who had some anterior segment findings. And, my adage has always been exotic lifestyles always lead to exotic conjunctivitis. So I asked him, I said, are you sexually active? His response was, not really. I just had to leave it there. I'm not really quite sure what not really meant, but I had to leave it there.
Yeah. So again, and this is, we'll get better on its own. Whatever the cause of the Valsalva is, it'll get better on its own. Now, some people have talked about with a intravitreal and doing like a laser, trying to laser it so the blood can leak out. Doesn't say poking it with a needle, but I don't think they're doing that so much. But it will kind of, blood will slowly clear. You kind of worry that sometimes it may clot, and it that if it clots, sometimes it can be takes a little bit longer for it to go away. But for some reason he didn't come back. And periodically I'll check on him to see what happened. Did he come back and see one of our retinal specialists? And he hasn't. But again, you can kind of see where is the hemorrhage: pre-retinal, subhyaloid, sub-internal limiting membrane. It's kind of a little difficult to know that, but no question, you can see that it's very, very superficial. So another one, this was again, kind of a little bit of a zebra here as well, but I think very interesting. This is a 76-year-old white male that I had been taking care of for many years. As you can see, he's got intermediate macular degeneration. He's had mild cataracts in the right eye. He had cataract surgery in the left eye some years ago, and he's pseudophakic in the left eye. And so this was in April of 2019, and he's 20/25 on that visit. I did an OCT, and I think you can see these kind of drusenoid PEDs that are present in each eye. He doesn't have any intraretinal fluid. Normal architecture for the most part, maybe a little epiretinal membrane in the left eye here, but no really fluid. Again, these kind of noise that you see underneath these little kind of pigment epithelial elevations represent these kind of drusenoid PEDs. And so I typically will see him every 6 months. He is on an ARAD supplement, but there we go. So here's where it gets interesting, right? So I had seen him 6 months earlier, and he comes in, this is the first week of December, and he says, during that Thanksgiving weekend, he was in Orlando. He was rear-ended at a high speed, ended up having loss of consciousness. He gets airlifted to a hospital, really doesn't remember much. Head was hit his head on a steering wheel. And in fact, he had a big laceration on his forehead. So you can kind of see where he'd had some kind of damage there. And he says that since the accident, he's got blurry vision in his right eye. And sure enough, you look at his acuity is 2150 in that right eye, and in the left eye, it's 20/25. And so here's what his retina looked like. Give you that kind of step back look. You can see the drusen are still present. This perhaps represents a little cotton wool spot. In the left eye, you see these kind of peculiar blot hemorrhages. Again, I'll kind of, I don't know why it takes a second for this to try to advance. Let me do, there we go. Kind of a up close and personal more at the macula. And again, you can see the RPE modeling, the kind of the drusenoid changes that we described earlier. Again, I think a little bit of a cotton wool spot, perhaps. And so again, we do our OCT, and it looks very similar, right? You see these kind of drusenoid PEDs, no fluid that's present. And by the way, this is really a cut that's right through the macula in both eyes. But if you notice, kind of in that area where the cotton wool spot is, on a little bit of a higher slice, you've got this kind of higher reflective change on the OCT in the right eye. Didn't really see it through the macula, but a little bit above the macula, you could see he's got this kind of higher reflective area within the inner retinal layers. And kind of correlating that clinical exam with the OCT, and I think we're kind of looking in this area here. Again, I did an OCT angiography on him. This is the OCTA, an 8x8 cut. And this is more of a superficial cut. And again, you look at these kind of same areas, and you can see that they're kind of hypo-reflective, kind of low flow, if you will, within the inner retinal layers associated with this kind of same area. Greg, I don't know if you want to comment. You do a lot of these OCT angiographies just like I do. Any thoughts when you look at this?
Oh, no, and not anything that you've pointed out. I mean, obviously, there's no flow. There's gaps showing up. There's areas of compromise.
Yeah. And so,
go back to that onphos. That onphos looks pretty cool right there.
I don't know what the onphos is. This is this kind of onphos image right here. So or you're looking on this one. On
no, that deep one there. Yeah.
I don't know what this represents, to be honest. So it's kind of little hyper reflective, if you will. And I don't know the significance. And as you saw, I think this really kind of represents a Purchur's like retinopathy that, again, when you get either chest compression, typically you get this kind of vaso-occlusive response. And usually, and I haven't seen many of these cases either. I mean, certainly when we'd work in the retina clinic, I would see him, but not as a patient who comes into my clinic, again, within a week of having a kind of a significant injury. So this was 6 days after his motor vehicle accident, and think of any kind of traumatic retinopathy, right? So this commotional, like the counter coup shock waves that traverse the eye, you can get swelling of the, of the sensory retina, swelling of the photoreceptor cells. And certainly that happens in kind of a commotional like setting. I think probably similarly with the Purchur's, you get these, again, this vaso-occlusive response that occurs. So it's described as this occlusive microvasculopathy associated with various forms of trauma, cranial trauma, thoracic compression, loss of vision, varying severity, occurs hours to days after the trauma. And again, excuse me, whitening of the retina. So that's kind of almost more of that commotio type presentation. You can get cotton wool spots. It can typically be more hemorrhagic, and that's how, whenever I've seen it, it's looked more like that. And this is in one of the cases that I just kind of looked in the literature, and it looks very similar, right? Not quite as, mine isn't quite as extensive as this is, but you see these kind of areas of whitening, but also on the OCTA, the same type of thing that we kind of looked at, and these kind of higher reflective areas on the B scan, very similar to what my patient had. So ischemia involving the inner retinal layers during the acute phase. The OCT can show this hyper-reflective and thickened inner retinal layers, just like what we just looked at. And then on OCTA, the shutdown of both the superficial and deep capillary networks, and that kind of correlates to that same area where you saw the hyper-reflective. And you can get disruption within the outer retinal layers. And depending on how bad the trauma is, the photoreceptors, of course, can die, and you can get that kind of bony pigment spiculum. And so it's thought that this increase in thoracic pressure leads to a reflux in the venous system, leading to endothelial damage. This results in incompetence of the microvascular circulation and subsequent occlusion and ischemia. And sometimes it's also thought that you can get ischemia from air or fat emboli as a result of that as well. So a couple of different thoughts on why this happens, whether it's, again, air or fat emboli, or again, just this reflex from the venous system. And so I ended up having him see one of our retinal specialists a week later. And they didn't really there's really nothing to do, right? You just kind of wait it out. They thought, the retinal specialist thought it was more related to his cataract. And so he ended up having a cataract surgery 2 or 3 months later. And when all was said and done, after his cataract, this was 6 or 8 months later, he came back to 2020, 2025. So it really did get better on its own. So I guess he's really pretty lucky.
And to kind of feed off what Dr. Shovelin has put into the chat box, Perchers like, he has flecking in there, there's Perchers, and then there's Perchers like, retinopathies, and then there's the flecking type. So I would say that that's probably what, that's that one onphos was pretty much representing there. So,
okay.
Yeah.
Good. Thanks.
Cool stuff.
Yeah. You're not going to see that every day, but again, when it's a patient that, you take care of, and then all of a sudden he comes in a week after having a pretty significant motor vehicle action. I thought it was really kind of interesting, and it was interesting to see ultimately as time went on, this did get better on its own, and it resolved, and he ended up doing really very well.
And I think the cool part about that, Mark, is just kind of knowing the anatomy, right? I went to PCO, and Dr. Lombardi was always about the anatomy, and just knowing how those angiographies work, superficial and deep, and that's in the inner retina, and that's exactly where those whitening spots was in that inner retina area. So kind of that fleckening area. So
yep.
And Mark, it's also interesting because this is case files from Bascom Palmer, how a fellow like Don Gass knew all of this without ever having the access to an OCT.
Correct. Exactly right. Well, Joe, your timing is good, because we're gonna get into that in this next case. And this was really kind of Dr. Gass's really passion, if you will, is he was great, right? He could see things and understand things and conceptualize things almost better than anybody. And one of the things that he really wanted to try to understand and figure out was, why do these macular holes develop? What was the kind of pathogenesis of developing a full thickness macular hole? Here's a 65-year-old white female who, unfortunately, luck is not on her side. She'd had a macular hole in the left eye that was well over a year before. And again, you don't need an OCT to make a diagnosis of a macular hole, but she was one of the, what Gass would estimate that it's like 12 to 15% of patients can get a macular hole in the fellow eye. And lo and behold, 6 weeks earlier, blurry vision. And so she comes in and she's got a macular hole now in her fellow eye, and she's 2100. Now, the images, again, you don't need an OCT to make a diagnosis, but they're really, obviously gives you a perspective that you just don't really have based on your clinical exam, and really a perspective that Dr. Gass didn't have either on the clinical exam. He tried to understand the pathophysiology. He would really scrutinize the vitreous, trying to understand that dynamic, that he knew there was traction that happens on the retina. And obviously that leads to tractional forces that ultimately leads to patients developing a full thickness macular hole. This one, the more chronic one, vitreous is probably, we kind of categorize as stage 4. You don't see the vitreous stuck there anymore. And so how do you think these macular holes developed? Do you think it's this kind of anterior posterior traction top to bottom? Do you think it's, go back. Do you think it's tangential or sideways traction? And that's what Gass kind of thought occurred. You get shrinkage of the vitreous and you get this kind of tangential traction. Do you think it's from peripheral retinal traction, or do you think it's this kind of perifoveal, almost an oblique traction? And again, it doesn't matter, but only because this is Bascom Palmer, and Gass had really spent, years trying to understand, and he wrote papers and books on it. And so what is the ultimate cause? What type of traction occurs that results in patients developing full thickness macular holes?
Mark, and I think this, even though it might seem kind of, getting into the weeds, but I think this is an important topic because it starts to then explain, maybe why lamellar holes look the way they do and pseudo holes the way they do, and why a macular hole forms. So, even though you might be, kind of going, well, what we're talking about here, I think is very important. So,
well, and it just really speaks to how, how good the OCT, because until we had OCT, we really just didn't understand. We just didn't get it. And now, we certainly see full thickness macular holes, but we also see these patients really during the journey of going on to develop a full thickness macular holes. We see the vitreomacular tractions and the early, tractions that occur. So Gass got it wrong, just so you know. So it wasn't sideways or tangential. It would make sense that it was anterior posterior, but it's really, when we first started doing OCT, it was this last one, this perifoveal, almost an oblique traction that occurs that leads to the development of these full thickness macular holes. And so we kind of understand how, you know, what they look like, what the vision is. We'll kind of skip through that. Again, he originally thought it was anterior posterior, and then 1989, he said it was, well, shrinkage of the vitreous that leads to this tangential traction. And of course, he came up with a staging that I don't know if it's still, you know, completely accepted. I think it's been modified, but this was, you know, kind of the early version of the OCT showing this perifoveal. So it's, you know, attached peripherally, but this perifoveal detached around the macula, except right in here. And that's what really causes these full thickness macular holes to occur. And so again, GAS just didn't have the ability to see it like we have with OCT imaging today.
Hey, Mark, just because we do a lot of teaching in this arena, I think just a quick reminder to the audience that the macula is huge. To the audience, remember the macula is 5.5 millimeters in size. It's, you know, 2 disc diameters, if you want to say. It's just inside the arcades. So basically, when you're looking at these OCT images, I mean, you're literally looking at the foveola, the parafoveal, and then the perifoveal area. So, you know, this whole area is the macula because we're really zooming in. You know, so I hear people talking, you know, like, oh, it's a macular this, macular, and it is a macular hole. I'm not saying anything to you about this, but remember out there, people, that the macula is huge. And that's why like 1 drusen within 2 disc diameters is considered macular degeneration. But when we look at these OCTs, we're literally looking at the foveola, the fovea, the parafovea, the perifoveal, and the macula even goes beyond that in some of these shots. So.
Yeah, we don't really think about that in that perspective. Well, certainly I don't when I'm looking at it. I mean, you know, the fovea really becomes kind of the critical area when we're looking, you know, at things that can affect vision and vision loss. But yeah, it's a good point. And this was one of the early cases that GAS presented. And so the idea is when these early stage macular holes develop, you know, you get loss of the foveal depression, patients would have metamorphopsia, and you would kind of see this kind of yellow ring. And so as kind of, I think Joe and in my bio had kind of talked about, I write the monthly retina quiz, and I've done this really since probably the early 1990s. And maybe some of you have been around long enough to remember that. If you read it, you might also remember that, you know, these histories were always really very interesting, right? So you look at this patient, this was a retina quiz that I did early on. This is a 72-year-old female mountain climber who's training to climb Mount Everest. You know, she's had macular hole in the left eye, and as she's training, unfortunately, she develops this early stage macular hole in the right eye. And of course, the drama is she going to be able to climb Mount Everest, right? And so, in fact, that was the history. Will eye problem stop her pursuit of Mount Everest? 72-year-old female mountain climber was training for one last climb up Mount Everest when she noticed a relatively rapid decrease in her vision in her right eye over a week. She had scaled the legendary giant once before and now wanted to be the oldest female ever to reach the summit. She was greatly concerned that she would not be able to fulfill this dream. And so the reality is that history was completely made up. She isn't a 72-year-old female mountain climber who's training to climb Mount Everest. But so I would kind of take some of these creative liberties with some of these cases. And in my mistake, and we'll look at a couple more in a second. I think you'll get a kick out of it. I used to be very entertained with it, but my mistake was that she wanted to be the oldest female mountain climber ever to reach the summit. Well, as I said, that's not true, because I remember coming to work on a Monday, and there was a voicemail message in my office from a lady who knew really the female history of mountain climbers. And there was somebody who was older than this patient to pursue and climb Mount Everest. And so, you know, unfortunately, she didn't leave her phone number, but, you know, I apparently got it wrong.
Well, Mark, you should never let the facts get in the way of a good story.
And usually I don't, right? here was a semi-retired British Secret Service agent who notices blurry vision on a high-speed chase on the busy streets of Paris. Again, that was a completely made-up history. It was, I think, a patient who had a branch retinal vein occlusion or something like that. And this was, when I was reading my Robert Ludlam books, I thought, oh, this would be kind of an interesting one. Here's I always got a kick out of, here's somebody who, a 52-year-old who's a professional mourner, and they noted blurred vision in both eyes. And so her job entails traveling by bus to various funeral homes where she is paid to attend funerals. So if you're, maybe you pass away and you don't have a lot of friends, this is somebody who gets paid to go to funerals and cries. And so I thought, wouldn't that be kind of an interesting profession? And so I had a bunch of these then where things really caught up to me. This was, again, in the era of Dan Marino. So I had a 26-year-old quarterback from the Miami Dolphins who was experiencing blurry vision and metamorphopathy in his left eye during training camp. He thought it would go away, but when the symptoms persisted for several days, he went to his eye doctor. And so, it was a patient who had a choroidal hemangioma, and they had a little, fluid leakage in the macula. And so it's interesting because nobody had really commented on my colorful histories, but for some reason, this one seemed to get some attention. I had some friends who would say, hey, was that Dan Marino? And I would say, no, it wasn't. I'd kind of tell them I just made it up. Well, again, this is a Monday and it's 5:00. I sit down at the end of the day and the phone rings and I pick it up, and it's the Miami Dolphins wanting to know if one of their quarterbacks had an eye problem that they weren't aware of. And of course I had to kind of grovel and like, well, no, it really wasn't. I just kind of made it up. And Harvey Green, he was a head of kind of public relations, and he was just really kind of an SOB, and he was being mean. He was threatening to go to the chairman and want to get me fired. And I'm like, wait a minute. I go, this isn't like New England Journal of Medicine. This is Review of Optometry. People read this in the bathroom. It's really not, that big a deal. And so he like makes me grovel for like 10 or 15 minutes. And finally he like says, all right, we'll kind of let it go this time, but don't do it again. And so that was kind of one of the last times I kind of took these creative liberties with some of the histories. One that I thought was kind of cool when around again, this was in the 1990s when the Star Wars was kind of coming back, and I go, I'm going to make it a Jedi Knight who's got blurry vision but then it didn't really matter because he's got the Force with him and he really doesn't need his vision. So ended up not doing that one. So anyhow, getting back to macular holes again, I think we see these all the time. It really does become a clinical diagnosis. And in the era of OCT, it really isn't that challenging. I remember before I started, right? So I was in the 1980s, even, we didn't have any treatment for macular holes until 1991. And this is kind of Kelly and Wendell, who were two retinal specialists in Orange County, California, were really the first ones to kind of report on doing this vitrectomy, removal of the cortical vitreous, injecting a gas bubble. And of course, that really led to this pioneering surgery, which is routinely done all the time on patients. In fact, I had another patient a couple of weeks ago had bilateral macular holes, had surgery, but he was 2020 in one eye, 2025 in the other. After having, this was like 8 or 9 years ago, he had macular hole surgery by Harry Flynn. Just another example, one of my patients, right? I had seen him 2 months earlier, normal eye exam. They work at the University of Miami, and she calls me up and says, gosh, I'm having blurred vision for the last 10 days. Can you see me? And of course, again, very typical, full thickness macular hole. And so imaged in this case with the Heidelberg spectralis. And again, just beautiful image. Ended up referring her to Tim Murray. Tim did the vitrectomy, membrane peel, gas bubble, and really she ended up doing really very, very well. And there she was, I think a month or so, 2 months after surgery at 2030, and did fine. It was always interesting because they couldn't explain why is it that patients have such good visual outcomes after having had macular hole surgery? Because remember, it was believed that this hole represented a plug of retinal tissue that was missing. Gass had reported that in about 50% of cases, you could see this little translucent operculum that was suspended above the hole. And so it was believed that you're missing a plug of retinal tissue. And if that was the case, though, why are you having such good visual outcomes? And to some degree, they said, well, it must be because if we get rid of the fluid, then that's probably why they're having such good visual outcomes. But interestingly, when they would do vitrectomies and they would analyze the vitreous, never once were they able to see or detect that plug of retinal tissue. And so instead, what you see happening is you're not missing a plug of retinal tissue. The tissue is there. It's kind of like that pair of blue jeans that gets pushed off to the side with time. And so when you kind of finally do the surgery, you're able to reoppose the retinal layers of the photoreceptor cells, and you're coming back. And again, it's evolved. It used to be face down positioning for 2 weeks, and then it kind of went down to a week. And now even within a few days, if they do an OCT and it looks like the hole is closed, many surgeons will stop it. And so I think it is definitely surgeon dependent, but certainly not at 2 weeks anymore, and probably a little less than a week even for most surgeons. And again, the idea is that the vitreous kind of provides that, kind of isolates the vitreous from the hole, but also provides that mechanical, tamponade of the macula to make sure that promotes hole closure.
Hey, Mark, a question came through, and it's, do lamellar holes often develop to full thickness? And if you, and maybe even touch upon the difference between a lamellar and a pseudohole. Sure.
Well, a lamellar hole is a pseudohole, but not all pseudoholes are lamellar holes. So our traditional thinking, right, with a pseudohole is there's an epiretinal membrane, and really what you're looking at is essentially a hole within the epiretinal membrane. So you may have normal architecture, you may have some irregularity of the architecture. So again, sometimes on an OCT, it'll look like a partial thickness. I'm trying to see, usually I always, I don't think I have it in the slide deck, but by definition, for it to be a lamellar hole, what you get is this partial thickness hole, but you also get this separation of the inner retinal layers from the outer retinal layers. So what almost looks like cystic spaces within the retina. And that's that separation of the inner retinal layers from the outer retinal layers. So a lamellar hole is a pseudohole, but not all pseudoholes are lamellar holes. And again, maybe on one of the talks that we do, and I think, this will inspire you guys to come back, because I think we're doing a clinical decisions talk in August. And I think I do actually talk specifically about lamellar holes, pseudoholes. And again, this isn't full thickness holes, but it really, this is kind of why OCT, I think, does a good job of kind of helping you see and appreciate, what's happening anatomically, but even structurally within the inner retinal layers. If you're starting to get those tractional forces and that separation of the inner retinal layers from the outer retinal layers.
And Mark, I know that it's unfair because you can't see the question, but John's asking, do lamellar holes often develop into full thickness holes? And John, the answer is no. Like in knowing retinal anatomy, the key is that the inner retina and the outer retina, it's like a cake. There's two layers, inner and outer, and the inner retina has the superficial and deep plexi. But that's why you'll see that's where a lot of the diabetic retinopathy, the hemorrhages, the fluid, because there's kind of a loose space in there. So when you start getting this traction here, like Mark is showing, you'll start to get that kind of in that little kind of bump area right there. If you want to point that out there, Mark, is kind of that separation. Go right there, boom. And then over, just kind of go up a little higher, go left and right now. That's your lamellar separation right there. You could see that inner retina splitting from the outer retina, but they don't always turn into, and
usually
rarely.
It's a little further down. So, the reason they don't develop into full thickness macular holes is usually because the vitreous is separated. So usually you've got already a posterior vitreous separation. So the traction is gone. Now, again, an aborted macular hole, you can get a partial thickness, and that can happen, or it can be a lamellar hole, but typically they don't progress. And this was kind of the example of what Gass was showing early on, these stage 1 macular holes. This patient's got this little kind of yellow change. They've got metamorphopsia, and you can see this patient is going to evolve into a full thickness macular hole. You've got changes within the outer retinal layers, as you see here. You've got this kind of broad, still vitreomacular adhesion here. And the question is, if this continues, does she go on to develop a full thickness macular hole? And again, you look at it and you can, again, she's 20/40, she has distortion, metamorphopsia, and she's symptomatic. Interestingly, here's the left eye, and you can kind of see that she's, it's not a partial thickness. I mean, the normal anatomy, this isn't a lamellar pseudohole or anything like that. She just got some traction and some kind of pseudocysts that are forming there. point is she ends up having a vitrectomy. I guess she was down to 20/80 and did pretty well. And you kind of look at the left eye, again, kind of the same thing, kind of marching towards perhaps developing a full thickness macular hole if this kind of
Your
progresses.
bottom picture would be now starting the definition through that cut would be kind of a maculoschisis is what that's kind of.
Exactly right. Now, this is a similar case, right? So this was another patient that I saw. So this is a different scenario where she's 20/40. She has some symptoms. Again, you can see the vitreomacular adhesion here. And you're starting to see some changes within the outer retinal layers. And I ended up kind of watching her, right? So she was 20/40. She comes back 9 weeks later, and now she's 20/50. Her symptoms are worse. And so at this point, I end up referring her to the retinal specialist. And interesting what happens by the time she gets to the retinal specialist, boom, vitreous separates, she detaches, and you kind of go back to this normal kind of anatomy, the normal architecture of the macula. So it's kind of interesting to see that evolution, and you wonder how often that occurs. These are patients that, maybe they never make it into the eye doctor and their symptoms go away. And of course, many who do make it in then end up kind of having full thickness macular holes, but she got lucky, right? Vitreous pulled away and she did fine. Last question I'm going to ask, and then we're going to end it just because for the sake of time. Do you know what scleropteria is? What is scleropteria? A severe infection resulting in total blindness, an open globe injury with total retinal detachment, an open globe injury. Oh, they were both. I think we had those wrong. I mean, because number C is a closed globe.
Oh, that's my fault from when I entered them.
Well, for the sake of time, we'll go. The answer is C. It's a closed globe injury that results from a high velocity missile-like object bumping but does not perforate the sclera. And this is an example where a picture is worth 1,000 words, right? So looking at the globe kind of tangentially hits the eye wall. So you get a rupture of choroid, Bruch's membrane, RPE, but not sclera. And so this is an example of a boy who gets hit in the eye with a BB gun, and the BB kind of hits the eye wall. And so again, you're looking at a large area of commotio. And this is our kind of area of scleropteria here, where you've got rupture of RPE, Bruch's membrane, and choroidal rupture as well, but intact sclera.
Hey, Mark, I'm going to end the poll here, and I'm going to share the results. But what I want to do is make a little announcement is I just shared in the chat box, and it says 1-S2, blah, 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 whatever that is. But it's a paper that I reference a lot in doing some OCT talks. It's from 2013. It's the International Vitreomacular Traction Study Group Classification of Vitreomacular Adhesion, Traction, and Macular Holes. Really cool because it goes through macular adhesion, vitreomacular traction, full thickness, that shift from stage 1, 2, 3, and 4 to the full thickness, and a lot of this terminology that you'll kind of see the retinologists use. So it's in the chat box. If you guys don't know how to do that and you want to email me, I'll send it to you. But it's a really, really cool paper. It's an easy read. I mean, you have to read it a couple times to get some of it down, but it's got some great pictures in there too.
Thanks, Greg. Yeah, I've heard you talk about it several times, and it is, again, in the era of OCT, just because our understanding and natural history and whatnot, we're able to kind of understand these mechanisms much better than we ever did. So let me just kind of show you how this kid ends up, and then we'll kind of call it a night. But so this is 2 days after his BB gun injury. He's got a lot going on. The question would be, what would you predict the final visual outcome in him is? Got a little serous fluid, ends up with a macular hole a week after that. So pretty significant traumatic injury, develops a macular hole. Of course, ends up having vitrectomy, gas bubble, face down positioning. Here's our macular hole. And here he is 6 weeks after repair, and he ended up, I think, 20/60, which is really remarkable. But to me, what was interesting, here he is 6 weeks after the surgery, and you see all this kind of bony pigment migration within the sensory retina, as a result of these kind of the death of the photoreceptor cells and RPE kind of migrating in. This is kind of the area where he had his scleropteria. And yeah, I think he ended up 20/60, really pretty good outcome. I mean, you look at his nerve, it looks great, right? Really ultimately did pretty well when all was said and done. And this was another example. This is, car accident, motor vehicle accident, almost the exact same scenario. Piece of glass that's lodged under, in the eye, in the orbit. And this patient also develops macular hole. You can kind of retinal detachment, really same scenario, but ends up not really having the outcome of what our kid had. But again, you see the piece of glass that really went through the eyelid here. And that was a grand rounds case. I never saw this kid, but thought it was interesting. So I think with that, we'll kind of skip this case and I'll kind of stop my share and we'll turn it back over to you, Joe and Greg, and just say thank you to everybody for your time and attention. And hopefully you enjoyed the cases. I certainly enjoyed having the chance to interact a little bit. And if there's questions, I'm happy to stay on and answer any of them.
Well, thank
Yeah,
you, Mark. I mean, I really enjoy it. I always like listening to you talk. I think I get a lot out of it. It was a very impressive presentation. I think I've heard this once before, and I really enjoyed it.
Thank you.
And it's great. You're at really the preeminent eye hospital in the country. You said what, 19 years in a row ranked #1.
Yep.
Thousands and thousands of patients, innovative treatments done there. But I think it would be remiss if you didn't acknowledge that you did have some help.
I had a ton of help. And it's never one person. Yeah, but yeah, I mean, working with great, with great people and students and residents and great ophthalmologists. So yeah, very lucky.
Well, it took all the way to the very end here for someone to write on our screen, but let's see if I can just clear it real quick. There we go. And Mark, I just want to say thank you. This was Case Files from Bascom Palmer. Mark did a great job. We appreciate it. And as the audience will see here, we'll have you back here very shortly.
Thank you, guys.
I don't see any further questions other than people saying, thanks, Mark. Thanks. Great lecture.
Thank you, guys. Yeah. Appreciate it. All right. Well, I'll sign off. You guys have a good rest of the evening and a good week ahead. Take care. Bye-bye.
Thank you, Mark. We're looking forward to seeing you back.
Thank you.